Welcome to our sixth and final Global Ovarian Cancer Charter Summit event. I'm Elisabeth Baugh, Chair of the World Ovarian Cancer Coalition, and I am delighted to see so many colleagues from around the world joining us today. For those of you who have been regular attendees of this Charter Summit series, you will know that over the past 12 months, we have used these sessions to explore each of the 6 global charter goals. We've covered everything from barriers that prevent more rapid diagnosis of ovarian cancer to accessing best possible treatment and the data that we need globally to build better cancer plans that include measures to address this disease. We've learned so much, but also these events have underlined what we concluded at the end of the Every Woman study in 2018, which is that no one country has it all right. And wherever you may be, whether that be a high-income or a low-income country, there will be challenges and opportunities that are unique to your setting. That is why it's so important that we share, through events like these, our wide range of global experiences and perspectives. As one contributor said, when it comes to ovarian cancer, we must ensure that the rising tide lifts all boats. I think this summarizes well the sentiments expressed in the Charter and these summit events. Indeed, throughout the series, we have seen outstanding examples of innovative practice, powerful collaborations between patients and clinicians, and an unwavering commitment to a shared goal of ensuring that every woman diagnosed with ovarian cancer has the best chance of survival and best quality of life possible, regardless of where she may live. We have shown that we are all capable of great things and how powerful we can be when we work together towards a common goal. As some of you may know, I'm stepping down as chair of the coalition in December. It has been such an honor to work with all of you. I'm happy I will remain on the board for the foreseeable future, and I'm very much looking forward to the next steps for the Charter and where this global movement will take us next. For now, I want to thank all of you who have joined and participated in this Charter Summit series. To date, we've had close to 700 in-person registrations for the series and just under 1,500 video downloads. We are hugely encouraged by the level of engagement from the global community. And I also want to thank our corporate partners for your support. We so appreciate all that you do and the important contribution you've made to these discussions and all of our work. Today's event is about family history and genetics, a topic that is becoming more relevant and important for ovarian cancer by the day. We have a great lineup of contributions from Malaysia, India, Australia, and the UK, covering novel approaches to raising awareness of the significance of family history, providing women access to counseling and testing services, and an approach to surveillance that may help avoid late diagnosis of the disease. As we work through the program, we encourage you to post any questions or comments you may have in the chat section on the platform, and we will do our best to make time during the panel discussion to address any points raised. With that, I will hand it over to Frances Reid, our World Ovarian Coalition Program Director. Frances will set the scene with a brief recap of our findings from the Every Woman study as they relate to family history and genetic testing. Thank you so much and enjoy.
Thank you very much, Elisabeth. So just a really quick reminder that the data was gathered in 2018 from 1,531 women from 44 countries who participated in the study. They were, you should note, mainly from high-income countries. So we asked women with ovarian cancer, before they were diagnosed, was there a family history of ovarian cancer? And the answer was that for 18.5%, the answer was yes, they had at least one member of their family who had ovarian cancer before they were diagnosed. You'll see there that the mother is the most common relative, and the second most common are both the maternal and paternal grandmothers. And that's a really important reminder that the genes that can become faulty and be passed down through generations don't just go through the female line in the family. When we asked them how many relatives they had with ovarian cancer, the answer was usually one. And You may know from most guidance that has existed in the past that you would need at least 2 members of your family affected by ovarian cancer to qualify for something like genetic testing. So by far the greatest number of women involved in our study only had one relative who had ovarian cancer before their own diagnosis. So definitely there wasn't an opportunity perhaps for them to be identified. We asked about breast cancer too. So this graph shows you that the teal colour and the purple together are 18.4% who had a relative with ovarian cancer. But you'll see that some of those also had a relative who had breast cancer, so that's the purple, and an ovarian cancer in their family history. And there was nearly another 30% who had a family history of breast cancer in their family. We asked about genetic testing before these women were diagnosed with their own ovarian cancer. So of those women with 2 or more cases of ovarian cancer or a case of ovarian and breast cancer in their families, only 20%, only 1 in 5 had been tested. So there were many opportunities actually to find these women before their own diagnosis. Germany was more likely to test women before their diagnosis based on their family history, with a third of women with 1 or more relatives being tested. So Germany was ahead of the game. We also asked about genetic testing after women were diagnosed, and this is important for 2 reasons. One is, of course, about access to treatments such as PARP inhibitors, where they're available and affordable. But the other is to identify where there is a familial link. And you can see a huge range here in the proportion of women diagnosed who underwent genetic testing based on the country that they live in. This data is from 2018 and is changing, we know that, but an awful lot of work to be done. And just to remind you or show you that of those women who were tested before their own diagnosis, just under half had a genetic mutation that was significant that was found, and the most common mutation was a BRCA1 mutation. So thank you for your attention, and with that I shall hand straight over to the World Ovarian Cancer Coalition Chief Executive, Clara MacKay.
Thank you, Frances. For the first main session of this event, I'm delighted to be joined by Dr. Adam Rosenthal, someone who has spent a considerable part of their career studying familial risk, as well as trialing approaches to minimizing risk and ensuring ways of ovarian cancer being picked up at the earliest opportunity possible. Dr. Rosenthal is an associate professor and consultant gynecologist at University College Hospital, London. He was the clinical lead on the UK familial ovarian cancer screening study, known to some of you as UK FOX, and more recently, medical director of the ALDO project, which has just reported on some results. Dr. Rosenthal is going to take us through some of the key points from both of these studies, and then we'll discuss some of the issues that arise from them. He'll also join us later today for our panel. So please do share any questions or comments that you have from this presentation, and do join us later for that discussion. Welcome, Dr. Rosenthal. Delighted to have you here, and I'll turn it over to you.
Thank you very much for the kind introduction, Clara, and thanks to the Coalition for asking me to speak on a subject which is very close to my heart. So I've entitled this Ovarian Cancer Surveillance for BRCA Carriers ? And hopefully there won't be a question mark at the end of it. I have a relevant disclosure, in particular Abcodia, who are the company that own the rights to the ROCA test, which I will be discussing today. Now, I think people would agree in general that, of course, the ideal goal of a high-risk population surveillance program would be to reduce the mortality from whichever cancer it is one's trying to detect earlier. But unfortunately, surveillance can't prevent ovarian cancer. And currently, no test has been shown to detect the majority of cancers prior to spread outside the ovary, which means that detection of the majority of cases at a curable stage would seem fairly unlikely at the moment. And confirmed high-risk women should therefore be offered risk-reducing surgery to remove the tubes and ovaries, because we have good evidence now that this does actually save lives. So I put it to you that the realistic current goal of high-risk population surveillance is to limit the morbidity of any cancer detected prior to a woman undergoing risk-reducing surgery. But it's absolutely crucial to remember that surveillance should only be used in those who are not ready or willing to have surgery, for example, because their family is not complete yet and they're unwilling to undergo premature menopause and maybe go on to HRT for many years. And certainly surveillance once a woman is on surveillance should not be used to delay surgery indefinitely, because that risks her developing a cancer prior to the onset of her risk-reducing surgery. So, does high-risk population surveillance achieve this goal? Well, I hope to use some evidence to convince you that it does. We started off looking at this in the early 2000s, and this was in the UK Familial Ovarian Cancer Screening Study Phase 1, or UK FOX. And this involved an annual CA125 and a transvaginal scan, but this was done locally by individual clinicians at multiple centres around the UK. And you can see some more important numbers about the study there, and you'll see that around 15% of the participants were BRCA carriers. And when we looked at the screening performance, actually it was really rather good in terms of sensitivity for picking up disease before it had caused any symptoms. And a positive predictive value was very high, meaning that we didn't operate on many women in order to detect one case of ovarian cancer. And the negative predictive value was high, which meant that if a woman's results were normal, it was very unlikely she was going to be diagnosed with an ovarian cancer in the following year. So at first sight, fairly impressive performance characteristics. And this seemed to translate in terms of clinical benefit to some downstaging. And this did seem to be significantly different when women were still on surveillance compared to when they weren't. And this, not surprisingly perhaps, translated into a reduction in those requiring aggressive surgery and helped them get down to a low level of residual disease. Now, this was in an era when we were still talking about optimal cytoreduction, defined as less than 1 centimetre of residual tumour at the end of surgery, whereas nowadays, of course, we talk about complete cytoreduction, meaning no visible disease. So some hints there that things were going quite well. And we concluded that we got acceptable performance and an apparent improvement in volume of disease and debulking rates, which of course might translate into a benefit in survival, but it's not possible to prove this with a non-randomized study. And we also noted that there were some potentially avoidable delays in the management of the patients, and lots of them were actually quite late getting their annual tests. And this was no doubt partly down to lack of central control of the surveillance. So we know that if you're going to do a national surveillance program, it's really important to have central call and recall to avoid people slipping through the net. And about this time, the ROCA test, which I'm now going to describe, had been adapted by Stephen Skates, the statistician who developed it with Ian Jacobs, for use in a high-risk population. So for those of you that aren't familiar with the ROCA test, this is looking at the level of CA125 tracked over time. And you can see on this logarithmic axis, on the vertical axis, some fairly high levels of CA125, all above 30 units per mil and many around 100 units per mil. But if you follow these individuals for a number of years, you can see that the levels stay horizontal or fall over time. And none of these women has an ovarian cancer, despite the fact that lots of their CA125 readings are high. But all of these women with exponentially rising levels of CA125 do have ovarian cancer. So what the algorithm does is it essentially compares an individual woman's pattern of CA125 over time and sees, does it more closely fit that exponential rising level seen in cancer or other kinds of fluctuations which are normal in women who don't have cancer. And the closer the profile is to the population who have cancer, the higher the risk that they currently have a cancer. And this is provided as an individual percentage risk that then allows you to triage women into different categories, those that carry on with normal surveillance every 4 months, or those who require intervention in terms of scans or appointments with a specialist gynecologist. And the adaptations that are used include taking into account not only the patient's age, but their menopausal status, and also the fact that they are at higher risk of cancer than the general population. So we used this in phase 2 of the UK FOX trial between 2007 and 2012. And again, we've got some figures here. And the women at this stage were carrying on with an annual scan in addition to their ROCA, but that scan was pulled forward in time if their ROCA test was concerning. And again, we've got quite a notable number of BRCA carriers on this trial, and some details there about the number of cancers in the BRCA carriers. And we looked again at the performance and found this to be really very good indeed. That positive predictive value of 42% is actually overall in BRCA carriers specifically. It's not as high as that if you look at women from other risk groups, because really BRCA carriers are the group who are most likely to develop ovarian cancer during the course of any such trial, because of course they're at the highest risk. And again, the negative predictive value was extremely high, meaning that it was really very unlikely that someone was going to be diagnosed with a clinical ovarian cancer through presenting with symptoms within a year of their last test. And we found some really good, I think really useful clinical benefits for the patients. So those that were diagnosed with really advanced disease, stage 3B or worse, reduced from 95% in those who'd not had a screen in the last year to just 37%, and that was significant. There was also a borderline significant reduction in those with significant residual disease, and a trend towards reduced surgical complexity, as you would expect in those who had a lower volume of disease at the point of diagnosis. And to put that in context, a score of 2 means you've just required a hysterectomy, removal of the tubes and ovaries, and removal of the omentum in order to get down to 0 residual disease. So by standard ovarian cancer surgery, a very low level of surgery compared to what might be required for someone with, for example, stage 3C disease. And also there was a significant reduction in the need for neoadjuvant chemotherapy to get women to a point that you could actually operate on them in the first place. And we've got some contemporaneous data, specifically from BRCA carriers, from the 2 publications noted at the bottom of the slide. And in those publications, the complete cytoreduction rate was only around 1 in 3 to 1 in 4 women. So you can see we did really quite a lot better than that. And on the basis of that very encouraging data, we decided to try to persuade the National Health Service in the UK to go ahead with a pilot national programme, not so much in the research setting, but in a real-world NHS delivered setting. And we presented this very recently at the European Society of Gynecological Oncology meeting. And to look at the methods, this is really very similar to what we did in UK FOX in terms of defining different levels of risk using the ROCA test, and then defining what happened to the women next according to what their ROCA test result was. So for example, if their current risk of cancer was less than 1 in 1,000, over on the left side of the slide in the green, the women continued with routine 4-monthly surveillance. But if you had a high level of risk, currently more than 1 in 33 of having ovarian cancer, then you were immediately referred to a gynecologist, and that's over on the right-hand side of the slide in red. And also there was a scan available for them to look at when they saw the patient. But we dispensed with the routine annual scan because on UK FOX phase 2, we'd really clearly established that women with a rising ROCA test often had a normal scan at the point of diagnosis because the test was diagnosing cancers earlier. And therefore, we didn't feel that using the scan would help us, at least at the point when the women didn't have abnormal ROCA results. And here are some sort of key numbers for the trial, study rather, and you can see that there are a similar number of BRCA carriers as there were in UK FOX phase 2. So then moving on to the actual achievements of this programme, we detected 6 cancers, and I'm glad to say that half of them were diagnosed at stages earlier than or equal to stage 3A. Again, we have a very high complete cytoreduction rate. And again, we have relatively low levels of surgical complexity, not for everyone, but for the majority of cases. So we seem to have got very similar results here in a real world setting to what we achieved on UK FOX in a strict research protocol setting. And what we've done on this slide is to combine the results on BRCA carriers only from UK FOX trial, phase 2, from ALDO, which I've just shown you, and also from 2 US trials, which were done at the similar time to UK FOX phase 2 in America, and published together in the same reference, which is shown there at the bottom of the screen. And what you can see here is that if women on the left-hand side who are no longer on surveillance were then diagnosed with a clinical ovarian cancer, 100% of them were diagnosed with a stage higher than 3A. That reduces to 3/4 of them if their cancer is detected at their first ever screen on surveillance. And of course, if it's detected at their first screen, you have no idea how long it's been there. It may have been there for 3 months or 6 months or a year without causing symptoms. So you have less of an opportunity to downstage if you diagnose the cancer with the first screen. But on the right-hand side, you've got the true measure of screening performance. In other words, if you've got someone having continuous testing every 4 months, and they then develop a cancer during the course of their ongoing surveillance, what do you find? You find that only around half of them are diagnosed with disease greater than stage 3A. And of course, that means disease, visible macroscopic disease outside of the pelvis. We also looked at the economics of doing this, at least in the UK setting. And I won't go through this in great detail, not least because I'm not an economist, but it does appear that there is some financial benefit to doing this. And this appears to be in the UK setting at least, because one is reducing the number of women who are eligible for PARP inhibitor therapy because one's diagnosing cancers at earlier stages. And against UK standard guidance at the moment, this means that fewer women will require PARP inhibitors, which of course we know are very expensive. So in conclusion, I hope I've convinced you that ROCA-based ovarian cancer surveillance in BRCA carriers who are not willing to have risk-reducing surgery is feasible and equally effective in a real-world setting as it is in the research setting. The downstaging that it achieves is very likely, in my view, to provide some clinical benefits to patients, and it may even be cost-saving, at least in the UK setting. Now, clearly, risk-reducing surgery remains the recommended management for these women. We must never forget this. But ROCA-based surveillance can be considered as a realistic damage limitation option for them until such time as they're willing to undergo this life-changing surgery. But clearly, it's essential to continue counselling such women when they're going through surveillance and not forget about their risk and continuously remind them about their option of undergoing risk-reducing surgery. So thank you for your attention. It just remains for me to briefly thank my collaborators around the UK who allowed us to do the ALDO programme, and also the other key members of the team. Thank you very much for your attention.
Thank you, Adam. That was so interesting, just really, really interesting. And it seems like very positive and encouraging results from the pilot. So what happens next? Where do you take this from here?
So we're currently preparing the paper based on ALDO, which is, we hope, going to include not only the clinical data, but also the economic data. And really the clock's sort of ticking on us for that with the UK situation, because I'm glad to report that one of our major national bodies that issues guidance to the whole National Health Service, called NICE, has now commissioned a guideline for women at high risk of ovarian cancer. And we know that surveillance is one of the things that will be included in that guidance. But of course, the guidance can only take into account published peer-reviewed information. And so that's why we want to get this out as quickly as possible, so that the people making the important decisions about future care of BRCA carriers in the United Kingdom will have this as evidence to help them decide if they feel that surveillance should indeed be offered as a national programme.
And that sounds like it's incredibly important to be able to sort of meet that timeline for that guidance, because it will clearly set the kind of standard of care or approach for women at high risk. And you make a point of talking about surveillance versus screening, and that feels like that's quite an important point to pull out.
Yes, I think that, I mean, as far as I'm aware, it's actually NICE, this body which I've just mentioned in the UK, that have decided that really we should be quite careful about our terminology. And screening refers to general population screening of people without symptoms. You're taking all comers and you're saying, do you maybe have a condition? Surveillance means you've already screened that general population using a method such as their family history or gene testing, and you've used that to define a high-risk population who are at greater risk of that disease. And for those women, you don't screen them because you've already done the screening to work out they're at high risk. What you do is you offer them surveillance in the hope you can detect either a pre-cancer, which unfortunately is, as we know, not currently possible in ovarian cancer, or in our case, earlier diagnosis at an earlier stage of an ovarian cancer, which we hope provides some clinical benefit.
And what would you say to people who suggest that maybe just, women at high risk go to their doctors, get an annual check? Is that, not the same sort of strategy?
I'm really hesitant to advise that. I think that in UK Fox phase 1, we showed there might be some benefit to that. But even though we didn't control the surveillance these women had directly, we know it was delivered by some really high quality local gynae-oncology clinicians who really were aware of all of the issues. I come across patients who get screened by their general practitioner or family practitioner, once a year because they think it's a good idea. But I really worry about how those tests are being interpreted. I think that in the absence of having ROCA testing available, if you have a gynecologist who really understands this specific area of medicine and is really good about tracking your CA125 level and understands all of the possible reasons for false positives, but at the same time understands that if you're a BRCA carrier, you have got a high risk of cancer, and therefore you've got to take a rising CA125 more seriously than you might do in someone else, then yes, if you can really satisfy all of those things, it probably is better than nothing. But in any surveillance or screening program, what you really need is high quality central control and call and recall systems and real experts looking at the results. And if you don't offer quality control at every step of that process, we all know from, for example, cervical screening programs that performance really deteriorates quite badly.
Yes, so I was interested. So you spoke in your presentation specifically about sort of the need for a national structure around a surveillance program so that it's systematic and, as you say, has sort of quality control just baked right into it from the beginning. So we've heard a lot in the last year or so, and most recently about UK CTOX, and there was much disappointment when the general population screening study failed to show benefit in terms of saving lives. Is it wise to draw conclusions from that in relation to familial screening?
Well, I think that it's an incredibly important lesson for cancer screening in general, that despite the fact that use of the ROCA test did downstage women in the general population with ovarian cancer, it didn't appear to translate into an obvious benefit in terms of reduced mortality. And that's a really valuable lesson for cancer screening. And it means you have to be cautious about using surrogate markers. But I think that at the same time, you've also got to recognise that there are big differences between the UK CTOX population and the populations we looked at in ALDO and the other ROCA-based surveillance programmes. So first of all, UK CTOX was women over the age of 50 who were postmenopausal and did not have a strong family history of ovarian cancer. And therefore, very few of them would have been unknown BRCA carriers, or should I say unwittingly been BRCA carriers. And we know that if you look at the histotypes of ovarian cancers on UK CTOX, around 2/3 are high-grade serous, whereas pretty much 100% of all BRCA carrier-associated ovarian cancers are high-grade serous. So you're dealing with different types of ovarian cancer in the two trials, and even the high-grade serous cancers in in UK CTOX, because they arise in the general population, many of those do not behave the same as BRCA-associated ovarian cancers, which we know tend to respond better to chemotherapy. And in addition, UK CTOX used annual surveillance rather than full monthly surveillance, as we did on UK FOX and on ALDO. The US trial the two trials used them every 3 months. So it's reasonable to expect that the more intense surveillance done on the high-risk surveillance trials would have created a greater level of downstaging than was achieved on UK CTOX. So I think to extrapolate directly from one trial to the other situation is not appropriate, but I do think it's a very important lesson that just because you downstage a cancer doesn't prove that you're going to actually save that woman's life. And that really was very clearly shown with the UK CTOX trial. I mean, I think if anything, if I may, that emphasizes the importance of constantly reminding women at high risk who are on some form of surveillance, that even if the cancer is picked up earlier because of the surveillance, that doesn't mean she's going to be cured. You've got to remind her of that, because otherwise she may get lulled into a false sense of security and put off risk-reducing surgery forever, which could be very dangerous.
Indeed. So I think 2 points there that are really important, which is, mortality is the kind of holy grail, but what we're talking about here is a downstage diagnosis, and that actually has quite a significant impact in terms of the severity of treatment and interventions, but also just, quality of life for those women involved. And I think the second point that's really important, and you've used this term before about this program isn't, it's not the only strategy. The surveillance, as you pointed out, may not impact on mortality, but it's a damage limitation strategy. I think you've described it as.
Yeah, I think so. And you may call it wishful thinking, but I think it's quite likely that these women's survival will be improved, even if it is not possible to enable a cure for them. And why do I say that? Well, we've got huge amounts of data now from the ovarian cancer literature that if you are able to completely cytoreduce a patient prior to them needing chemotherapy, so you're not needing to do neoadjuvant chemotherapy first, and you're able to do one operation and get them down to no visible disease, this translates into improved survival. And I don't really understand why it should be any different in the setting of the BRCA carriers on surveillance. We've shown a reduced need for neoadjuvant chemotherapy. We've shown a very high rate of complete cytoreduction. And we've shown that was achieved with lower levels of surgery than the so-called ultra-radical surgery, which many women now have to go through in order to get to that zero residual disease status that we know provides them with improved survival. So whilst I'm never going to claim that we've cured a single woman of ovarian cancer on any of our high-risk trials, I think at the same time it would be wrong of me not to hypothesize that we've at very least improved their survival somewhat, although it's impossible to prove that because these were not randomized controlled trials.
Thank you. Such an important point. And just what do you advise women with BRCA mutations in relation to managing their risk? What would your advice be?
So it's going to depend, of course, very much on their age and their personal experience of ovarian cancer in their family, which not all of them have, and also whether they're willing to subject themselves to premature menopause and curtail their family wishes potentially. But in general, we would offer risk-reducing surgery from the age of 35 in BRCA1 carriers and from the age of 40 in BRCA2 carriers. That would be modified if there'd been a particularly early onset cancer in that woman's family, early onset ovarian cancer. We know that breast cancer age of onset doesn't influence age of ovarian cancer onset. But I would also, if they're particularly concerned about premature menopause and loss of fertility, I would I would offer them recruitment to the Protector trial in the UK, which is the trial we've got in the UK going on looking at offering early salpingectomy only with delayed oophorectomy at a later stage in that woman's reproductive life. And I know that there are many other trials going on around the world looking at this option because we know that a very high proportion, nearly all of the ovarian cancers and BRCA carriers seem to start at the end of the fallopian tube, and therefore we assume, but we haven't yet proven, that removal of the fallopian tubes will provide a high level of protection. But there are various theoretical reasons as to why it might not provide complete protection, and for that reason it's only being offered in the UK as part of a clinical trial so that we can follow these women up and see what happens. And my colleague, Professor Ranjit Manchanda, is leading that work in the UK. But as I say, many other countries around the world have also set up similar trials for this really important question, because it would be wonderful if before my career is over, we could offer women an option to reduce their level of risk really significantly, but without depriving them of the option of having more children or having a natural menopause and not having to take hormone replacement therapy, which we know can't guarantee they will feel the same afterwards as they did before they had their ovaries removed.
So interesting. And, you know, you've just kind of underlined the really important decisions that women need to take, and you know, and they're hard ones as well. So on that, I just wanted to thank you so much for that, Adam. It was just a really interesting presentation and some really provocative thinking around there. And we wish you all the best with your work with NICE and your further trials. I know you're going to be back with us for our final session, our panel discussion later today. So if anyone has any questions or comments, please share them with us. I know Adam would be delighted to respond to them during that session. But for now, I'm going to hand back to my colleague, Frances Reid, for our next session in this afternoon's meeting. Thank you so much.
Thank you very much.